Great, thanks very much. I see there's some questions. I don't know what they are. There we go. All right, well, welcome everyone. Hopefully you're in a nice, cool, air-conditioned place, able to enjoy this comfortably. And this is such an important topic. I had the great privilege of being on the ASAM steering committee for many years and got to know and really appreciate the hard work that the ASAM folks put into their products and their thinking and their advocacy for quality treatment and quality guidelines and practical guidelines to help direct our practice in the field of addiction. So this came out of a lot of that work with that organization. So I really love presenting on this topic. And right away, you don't get to rest, our first poll.
Well, you're not kidding. Here we go.
All right, how many levels of care does your agency or in your practice do you have access to for working with folks with gambling disorder? How many levels of care are available within your agency, or do you have access to in your network of providers? 1, 2, 3. All right. Yeah, 100. Thank you for your response so quickly. That's pretty typical. The majority of regions, of jurisdictions, of practices have one level of care for gambling disorder. So just to keep in mind as we're talking about this ideal of levels of care, you know, how does that apply to working with clients who are dealing with problematic gambling in their lives? And, you know, to be noodling around, how can we get creative in addressing their needs for perhaps much more of a continuum of levels of care than is easily accessible, or perhaps at least equally as important, reimbursable? And how do we advocate for both of those things? Okay, so okay, so let's just start with ASAM's definition of addiction. And let me just state that ASAM has in its current manual a lovely, lovely chapter on gambling disorder that's really nicely done. So if you've not read it, find a copy of that book and read the chapter, make a copy of that chapter. It's well worth it. And they define addiction as, you know, this chronic disease of brain reward, motivation, memory, and related circuitry. That's a lot of the brain. And it applies, as we know now, because of the research done on brain mechanisms of gambling disorder, you know, comparable brain circuitry that gets lit up, that, you know, the reward of gambling affects in much the same way as the reward of substances. And dysfunction in these circuits lead to the characteristic biopsychosocial and spiritual characteristics of the disorder, of substance use disorder as well as gambling disorder, reflected in individual pathology, pursuing reward, or how reward gets processed in the brain with biological vulnerability to dysfunctions in reward processing that we see by substance use and other addictive behaviors, In DSM-5, we know gambling disorder is the only non-substance related disorder included in the substance use and addiction category. Because in large part due to the efforts and the work of researchers showing the comparability in terms of brain function and dysfunction and neurobiology that's shared by gambling as well as substance-related disorders. And it's characterized by inability to consistently abstain, impairment in behavioral controls, sticking to limits, sticking to whatever goals one sets for oneself in terms of this behavior, craving, diminished recognition of significant problems with one's behaviors, relationships, dysfunctional emotional responses. Like other chronic diseases, addiction involves cycles of recurrence and remission. And let me encourage you to think of recurrence or relapse, not just in terms of abstinence and not abstinence models, but in terms of harm reduction models where relapse can include not sticking to the limits that I've set. So not just do I gamble or not gamble, but do I gamble excessively? Do I go beyond my spending and time limits that I've set for myself or other limits? So again, we broaden that definition. Without treatment or engagement in recovery activities, addiction may be progressive and can result in disability or premature death. Whether we're talking about substances or gambling, these are deadly disorders, life-threatening disorders, and certainly can contribute to disability as well. Now, let me also say, maybe we're, going beyond the spectrum here. And I guess recovery activities relates because even without structured recovery activities, without going to self-help meetings or 12-step meetings, we have research that shows that people who recover, quote, naturally, without seeing a counselor or engaging in any of these more structured recovery groups or activities, people use the same strategies, the same kinds of cognitive behavioral strategies, the same types of recovery found in other self-help groups. Somehow they come upon those on their own, either through looking up things on the internet or reading or whatever it is. So they engage in the same range of recovery activities that are found in more structured and traditional sources. Another poll. Okay, somebody said they had actually 3 levels of care available to them. That is wonderful and rare. And we'll talk more about that later when we talk about the levels of care. So here's the next one. And we are giving you lovely, easy ones. So without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. We're not even taxing your memory overly. True or false? Yeah, we just said that. We would broaden that definition of recovery activities to include self-structured or self-engaged in, as well as more group structured activities or professional counseling structured activities. All right, very good. So 96%. There you go. And just to review, because these are really important when we think about how we're structuring our work in our programs. So ASAM has been a leader in saying we need to move beyond one-dimensional to multi-dimensional treatment and assessments. We're not just treating addiction, we're treating complex human beings who have many dimensions in our activities, in our behaviors, in our experiences that contribute to addiction treatment. So we go beyond the diagnosis as justification for treatment modality or intensity. It's not just how severe is your gambling disorder or substance, but what are the other factors that we're dealing with, to a much more holistic model that addresses the multiple needs: emotional, psychological, trauma-related, financial, situational. And ASAM has 6 dimensions of care that they suggest be looked at very carefully. And for gambling, I've added a 7th, a financial dimension, because I think finances are so important when it comes to gambling disorder that it really requires its own unique dimension. And moving from program-driven to individualized and person-centered care, not what does our program provide and how do you fit into that, but what do you need and how can we accommodate those needs within our program? So moving from fixed length of services to individualized and flexible length of care, and also moving beyond one size fits all care. You know, I worked in Maryland with one program who really, you know, wanted to integrate gambling into what they did. And they were an IOP program. IOP, intensive outpatient, is what they did. Now, when you went to that program, you got the groups, you know, whatever it was, I forget, 3 or 4 nights a week, the family program. You didn't get individual treatment, whether you needed it or not, you know, and I found that problematic because people needed the intensity of the group activities and the psychoeducation activities more than, you know, a few nights a week. But they might also need some individual attention, especially if they were the only person with a gambling disorder in the program at that time. And so they were sitting in all these group activities with folks with substance-related disorders. And in order to really meet their needs, they could have really benefited from a bit more individual attention to supplement the group interaction that they were getting. And that flexible length of care is really important. You know, 28-day programs started because that's what insurance companies would reimburse for. So that's why we had all these 28-day programs, not because there was any evidence basis for that. Now, it may not be far off in terms of how long it takes the brain to change and heal and begin thinking more clearly and things like that. But we recognize research on the correlation between the longer somebody participates in the continuum of care, the more likely the positive outcome. And as we'll talk about, that moves us from an acute care model of care, you know, like the broken arm model of care. Oh, we're going to fix your broken arm and we'll put it in the cast and then it'll be out of the cast, then we'll have some physical therapy and then you're done. Your arm is good to go. You don't need lifetime care for your broken arm, which is much different than a hypertension, a high blood pressure model of care, or a diabetes model of care that's much more multidimensional and requires ongoing monitoring over the lifespan. And moving from a limited number of unique and discrete levels of care to a model that's a much broader, more flexible continuum of care. And while, as we'll look at, the levels of care as ASAM lays out, you have 0.5, you have 1, you have 1.5, it looks like, you have these discrete levels of care that meet these criteria. That's only because we don't know how to talk about a continuum, a flexible, fluid continuum. These are just kind of guideposts within that continuum to help you know how that flow is going from the least intensive to the most intensive. But how we can have some flexibility within that is the key. So those are just benchmarks. But how do we use these benchmarks much more flexibly? For gambling disorders, we've already seen, given often limited resources and the lack of an aggregation of clients that would make a problem gambling specific intensive outpatient program feasible. We don't have enough clients to make, to fill a group of 6 to 8 clients on an ongoing basis for an intensive outpatient program. In our area, in our county, we don't have enough folks with gambling disorder needing a residential level of care to have a specific residential gambling treatment program in every county in the state. So how do we get some flexibility around that? Being creative, flexible, integrating into other addiction programs, so we can maximize the continuum of care for folks with a gambling disorder, where we can't have specific programs just for gambling at every level of care. So it demands much more creativity and flexibility. Clarifying the goals of treatment, making sure it's individualized, collaborative, that we're doing this together with our clients. We're not telling them what their treatment plan is. We're developing a plan of care, a plan of recovery collaboratively in a way that best meets their goals and their needs. Establishing that therapeutic alliance, not just top down, but together with. Identifying priorities or problems, obstacles to recovery, knowledge or skill deficits that are based on the client's priorities, not ours, and not the program priorities, including the client's strengths, their skills, their resources, as well as their obstacles and deficits. And establishing goals, the SMART goals are so important, goals that are specific, measurable, realistic, achievable, well-defined, time limited, so we know by when, and we know whose responsibilities. What are the goals for the client? What are the goals for me to accomplish, for me to offer as a clinician? That accountability, identifying who's responsible for what. The client, a family member, counselors, staff, sponsors, other people in the recovery network, and a timetable for follow through, so we know. We'd like to revisit this at this point in time to see what's been accomplished. And if we're not meeting our goals, what are the next steps? What's plan B? What options have been discussed? And this really facilitates knowing if what we're doing is helping as defined by the client, not as defined by me. How will you know if what we're doing together is working, is meeting your needs? What will that look like? And really defining that very clearly so we can measure it. And if it's not working, let's do something else. Or let's find somebody else to help us, help you meet your goals if what we have to offer, what I have to offer isn't working. Accountability, not just for our clients, but for us as professionals as well. Let me check in here on the chats. Okay. Okay. I thought there were new ones, but I can't see any new ones. Am I missing something?
No, I think, Dr. Rugle, we just had Adrienne has, she's confirming what you're saying with a couple of truths there. Yeah. So.
Oh, okay. Got it. I thought, was that the last poll? What am I doing here?
No, it's all right. That's what I thought. Adrienne might have been answering the poll too, but we got you. No worries.
Thanks, Adrienne. All right. And moving away, you know, it used to be, well, you move up to the next level of care if, you know, you didn't succeed in meeting your goals at the last level of care. That meant you had to start out at the lowest level of care and work your way up to graduate school. You know, that's not how it works. If somebody comes in and they're suicidal, I'm not going to work with them on, you know, early intervention strategies or levels of care or even standard outpatient. You know, we're going to go right to the level of care you need at this moment. And certainly creating an interdisciplinary team approach with medical care. And for, you know, we think of substances and we think perhaps of the need for medical care or medical detox, but folks with gambling disorders need that team. They may not have had history and physical and their annual checkup for the last 10 years. So we need to make sure what physically is going on. And we know from research that folks with gambling disorder have often just as many medical problems other than in the area of liver disease than folks with substance use because they've neglected their care and they've been living a very stressful lifestyle that hasn't addressed maintaining themselves with exercise and diet and sleep and all of that. And they also may need psychiatric care and medications to help supplement with their co-occurring disorders, and financial, you know, so with gambling, we bring in the financial counseling as well, and that becomes part of the interdisciplinary team approach. Questions or comments so far, just on the guidelines and principles and kind of foundational stuff? Okay. Don't see anything, so we will forge ahead. So these are all the ASAM levels of care. And what they've done, you know, in their current manual is done a nice crosswalk in terms of what does this mean for gambling, and we'll look at that. So how are these relevant to gambling? Well, early intervention, level 0.5, they speak to the prevention of excessive gambling. And certainly when we're working with high-risk groups, particularly folks in treatment for substance use disorders or in recovery from a substance use disorder or mental health disorders, those high-risk groups, what we want to do for everybody who comes into treatment for those disorders is do some prevention, because they're a high-risk group, and provide some education, you know, whether they're even gambling or not. This could be waiting for you. Be aware. Let's not go there if we don't need to. And doing some screening. Are folks in these risk groups, even in primary care, because we talked about the medical problems they may be experiencing, doing that initial screening and brief intervention and following that expert screening, brief intervention, and referral model for these high-risk individuals. Level 1, standard outpatient. And with gambling disorder, that often involves, you know, seeing a counselor. And rarely even are groups available that may be gambling specific. So it's often individual and or family couples counseling that we're talking about when it comes to gambling disorder. Now, I must say, with the pandemic, one of the benefits of the pandemic is it opened the door to doing online work. So if you can't aggregate a group of folks who are dealing with gambling disorder in your practice or in your, you know, catchment area, we can offer this online. We can do an online group or a hybrid. I know of one organization that's doing an in-person group plus an online group. So some people are there in person and some people join the group online, so that you have a sufficient number of folks to do the kind of group work that's most helpful. So we can use this technology to overcome the limitations of space and geography to offer more group options and psychoeducational options to folks dealing with gambling problems as well as their family members. Other jurisdictions are doing family educational groups online to bring people throughout a state together. So, you know, thank you, pandemic. Intensive outpatient, 2.1, 9 or more hours of service per week to treat multidimensional instability, you know, intensive outpatient. And again, very, very few. I think there may be one in Las Vegas. Now, I'm not sure where else in the country there may be gambling specific intensive outpatient programs. And when I say gambling specific, where the group consists of only individuals who are dealing with a gambling disorder. They may have other co-occurring issues, substance use or mental health, depression, anxiety. But the focus of the IOP is specifically on helping them with their gambling disorder. You know, thinking about ways that we can do this more with online options and integrating gambling into existing IOPs, substance use IOPs, that involves more than simply saying, oh, we've got an IOP, a substance use IOP, come on in, just we'll fit you into that. It requires more planning so that the person with the gambling disorder doesn't end up feeling even more alienated than they already are feeling. It's more than just saying, oh yeah, and when we say alcohol or drugs, just think gambling. You have to adapt your program to make it relevant to and appropriate for people with gambling disorders as well as people with substance use disorders. You have to rewrite your materials. Now, it's not, brain science here we're talking about. You don't have to be a neurosurgeon to do this, but it does take thought, and you should bring together a multidisciplinary team, including folks with gambling disorder expertise and experience, to make sure you're getting it right. And have counselors who understand all of the disorders that you're inviting into that IOP. So people who are competent to deal with gambling as well as substance use, and make the translation, and to make sure ongoingly that everybody's on the same page. So it's a thoughtful process, hopefully. And partial hospitalization, I don't know of any gambling specific partial hospitalization programs, and most of the ones I've encountered are for mental health issues that may be the co-occurring issues that somebody with a gambling disorder is dealing with, and not specific to just the gambling disorder. So let's look at Jennifer here. Jennifer is 28 years old, a single mother of a 1-year-old. She's in medication-assisted treatment for an opiate use disorder. She's been doing well on Suboxone and counseling, and has had negative toxicology screens for the past 6 months. She's working and has been able to save up some money. To reward herself, she's gone to the casino a couple of times with friends. She really likes the atmosphere there. It's exciting, and she loves relaxing at the slots. Going to the casino seems to fill a void in her life since she has stopped using drugs. Okay, so my question to you is, what level of care would we be thinking of for Jennifer? And feel free to type it into the chat. Yeah. IOP 0.5, early intervention. Now we're just talking about the issue of gambling here, not her substance use. IOP, traditional outpatient, 1.5, 1.5. Okay, thank you for your comments. Thank you so much. Yeah, 0.5, 1, kind of going back and forth between 0.5 and 1. She is working. She has a 1-year-old. Yeah, single mother. So from the information we have here, does Jennifer meet criteria for having a gambling disorder? Yeah, and you can type, does she meet criteria for having a gambling disorder? Would she even screen positive for an indicator, any indicator, that she's got a gambling problem? A raised hand.
Yeah, Willie says he raised his hand here, Dr. Rugle. He's saying 1. Yep.
1. Yeah, Marge Zakowski has a raised hand, so I don't know. What we're looking at here, not sure. We don't have enough information. Is she chasing her losses? No, she's so far, she's sticking with her budget. She hasn't exceeded the times she goes. She's not neglecting her baby and leaving the baby at home while she goes gambling. She's just gone there a couple of times, just a couple of times, and liked it. Now, what may cause us some concern is her statement that it seems to fill a void in her life. She doesn't meet criteria for a disorder. It's not creating any problem. She's not showing any signs of loss of control yet. So this would be probably 0.5. We can't assume that everybody who's at high risk, if they start gambling, is going to develop a problem, but we want to educate them. We want to prevent Jennifer from going forward. We want to, explore with her what would be some warning signs. We want to let her know you're at high risk for developing a gambling problem. How would you know if you're heading in that direction? Here are some of the signs and symptoms. Here are some of the warning signs. Hopefully, in whatever treatment program she's in, there's been some information provided, but does that usually happen in a program where she's getting her Suboxone? Would we assume that she's gotten information and education and some prevention on gambling disorder? No, we are not there yet. Most programs don't provide that. Would it be my advocacy and recommendation that they do? Absolutely. But, if you're Jennifer's counselor, this may fall on you. To hand her a brochure and go over it with her. To say, that void, is saying, whoa, this could be a sequential addiction that you might fall into without even being aware of what's happening to you. Let's be aware of how to keep it safe. You don't want to tell her at this point necessarily, you better stop it. Don't ever go back to that casino. But let's be aware of the slippery slope and some guidelines to keep it safe. Set limits on time and money. How much can you afford on this form of recreation? How often can you afford to go? How often can you afford a babysitter? How often are you comfortable leaving your 1-year-old with grandma or with a babysitter? And what are you going to do if you start exceeding those limits? Where can you go to get help in order to stay within your limits? So yeah, more than likely, absolutely, motivational interviewing is key. Absolutely. It's nice to have fun in recovery. What's recovery-oriented fun look like for you? What's the cost benefit? Let's monitor this. This is an experiment. I don't know if this is going to become a problem for you. But we can set the guidelines and come up with your list of warning signs so that you would know if you're heading in that problematic direction, if the costs are outweighing the benefits, and are there other ways that may be lower risk of having fun and relaxing in your recovery. All those interventions. Good job with your comments. Thank you for that. All right. So another poll. What's our magical poll question this time?
Okay, it's coming. I'm a little slow today. Here we go. Stop sharing. Oh, here we are. Here we go.
All right. According to ASAM criteria, what constitutes 0.5 level of care? Yes, you should know that. See, we're not taxing our memories. I so appreciate that at this stage of my life. I don't want a memory test. All right, 0.5. All right, very good. It is early intervention. Yeah, 0.5, early brief intervention. 1 moves it up to traditional outpatient, once a week care, group or individual, anything, less than 9 hours is standard outpatient. All right. Role play barriers and obstacles, Adrian says, yeah. Let her learn with bumpers. Let's put in what we can, especially, if we're doing this in a harm reduction model, okay, you want to gamble, what are the warning signs? And just in case it gets out of control, is there anything protective we can put into place? Can you make sure that some of your money, is inaccessible? If this is going to be part of, can you put it in a certificate of deposit? What else do you want to do with your money in recovery? Are there other things that you want to put it away for? Have your fund and put that in a jar. See if you can stay within that. So a lot of work can be done around that early intervention piece. And if she's motivated, the trick is, gee, let's take this assessment tool, the Problem Gambling Severity Index, and see where you're at. So it might be that brief intervention. Let's do a bit of an assessment to see where you fall, where your risk category is. And the Problem Gambling Severity Index is a really nice instrument because on each of, I think it's 9 items, the person scores themselves on, 1 to 4 scale. So you get a pretty broad range of responses, and it tells you if you're at low risk, at moderate risk, or problematic level. So you get that range of feedback that can be so helpful in that early intervention, just to take a look at yourself and decide what you want to do with that information. All right. So yeah, now the question is, do you have in your system the process of that early intervention for giving education and information to your clients? Especially if you're seeing clients primarily for something else, for substance use or mental health. Do you have, as part of your practice, as part of your program, early screening and brief intervention? Do you have other education options, psychoeducation options, to let people know what their risk status is and how to set safe and healthy gambling guidelines for themselves? And if you'd like to put one in, what do you think that would look like in your practice or your agency or your organization? Yeah, not as much for gambling as we do for other substance-related disorders. Yeah, so what would it look like if you beefed up that early intervention for gambling? Yeah, we may ask the questions. Now, and what happens, and that's my whole other presentation, is nobody tends to say yes. And, in many organizations, it's one and done. Oh, we put in those 2, questions, the lie bet questionnaire, or those 3 items, from the brief biosocial gambling screen, And we ask them, you know, as part of this huge intake assessment, nobody ever says yes to those, and then they never hear about gambling again. You know, that can be beefed up. You don't ask just once and forget about it. You put, yeah, in an educational group on how to have fun in recovery, how to deal with your finances in recovery, how to gamble safely in recovery, how to enjoy, you know, don't give the problem gambling lecture. And monitor, ask again when you update the person's recovery plan or their treatment plan. Let me just check in on some of these other behaviors to see if, you know, anything is going on with those. So you ask the gambling questions again. And check in. Yeah, how are you doing with your finances? How are you trying to make some more money? How are you having fun with your money? Is that creating any problems for you? Good comments. But think about this, you know, how would a early intervention comprehensive part of our program look like in terms of gambling? And where could we improve that? Sue-Ann has always enjoyed going to the casino. She's typically gone a couple of times a month and enjoys playing poker and blackjack. She has almost always been able to stick to her limits. Recently, she's been going several times a week, spending more and more money than she knows she can afford. She just can't seem to stop herself. So, what level of care might we start out with Sue-Ann? Again, feel free to chat it in. You know, she's been okay, but now something shifted and she's exceeding her limits and struggling. Yeah, outpatient level one. Yeah, she's not. You know, again, of course, you want more information. You know, how distressing is this to her? You know, how bad has it gotten in terms of her finances? Are there other emotional issues? But from what we're presented here, certainly starting out with standard outpatient to see how we can help her get back to where she was, or assess whether or not she needs to disengage from gambling and, you know, go with abstinence. Or if it's a harm reduction approach, what are the limits we can set with her? Can she stick to those limits? Do we need to especially engage some bumpers like protecting her finances? Absolutely. Okay, thank you so much for your responses. Good job. Okay, now let's move on to, so again, when we look at level 1 to level 2.5, you know, what do we have to offer? What do you have in your systems of care for these levels? How would you handle a person? Do you have somebody who's competent, who's qualified as a gambling counselor to provide level 1 services? Do you have intensive outpatient? Have you adapted your intensive outpatient for substance use care so that a person with a gambling disorder can be adequately handled? You know, do you have a partial hospitalization where people know how to address gambling as a co-occurring issue when somebody is so depressed or so anxious or has severe obsessive compulsive disorder and needs a partial hospitalization program for that, or schizophrenia or schizoaffective disorder? Do you have somebody in that program who also understands gambling and its impact on those mental health disorders? hopefully you can begin to see the work that might need to be done to create something that's appropriate and effective for somebody with a gambling disorder at these more intense levels of care that folks with gambling disorder do need. At the very minimum, if somebody you're seeing has a gambling disorder and they have severe obsessive compulsive disorder and really require a partial hospitalization to structure their time and to help in their recovery process. And they've never treated somebody with a co-occurring gambling disorder, you might consult with them and educate them and create that treatment team to see even which activities that, the program offers. If they offer bingo, maybe we can talk about what else they can do. If for a social activity, they decide to have a casino night, as one of the programs I worked with did, can you see if they might have a board games night rather than a casino night? So you run into these kind of issues, and we have to collaborate to help people understand if they haven't had the training, and advocate for our client with a gambling disorder. All right, poll 4.
Okay, here we go. Let's see here, stop sharing. Number 4.
All right, intensive outpatient includes a minimum of 15 or more hours. This is getting a little trickier, huh? According to ASAM criteria, a minimum of how many hours is IOP? All right. All right, okay. Let me end the poll. Most people have answered. More of a mixed bag for this one. And most people said false, which is true, is correct. IOP criteria per ASAM is 9 or more hours a week. And it gets confusing because different programs have different requirements. So if you think about your own program, it may offer more than ASAM offers. But for ASAM to be IOP, and if most states adopt that, the criteria is at least 9 hours a week. All right. There we go. Get out of that. Okay, at least 9, yeah. Yeah, alternative activities that don't involve gambling. And, when I worked at the Veterans Administration, the volunteers offered daily bingo games. Couldn't get them to budge. We did get the pool table removed from the day room on our treatment program, and we did get the substance use treatment program volunteers not to run a monthly casino night for the folks in substance use disorder treatment. So small gains. Only took, 15 years to make that happen, but you keep chugging along. Okay, so now we're into residential levels of care. And 3.1 is halfway house service. For gambling, certainly can be helpful for those requiring transitional living. If you've blown all your money and you have tens or hundreds of thousands of dollars of debt and you're homeless, some sort of living accommodation can be very useful. Unfortunately, as with many things related to problem gambling, existing halfway houses often feel that they can't accommodate those with a gambling problem. Or if they can't accommodate, need some help in structuring their program to meet the needs of those with a gambling disorder. So it can be a challenge. You had to argue with many a halfway house director that they might be required by state regs to take somebody with a gambling disorder, or work with them and say, look, we'll provide the support. And it's scary. They have no experience with it. They may be, staffed by folks with lived experience with substance use disorder who have no lived experience with gambling disorder, or there may be a lot of gambling going on at the halfway house that they don't want to disrupt. That's what our folks do when they're bored. So it can be any number of reasons, but can be a rare resource, and we have to develop those more because it's an important part of the continuum of services. And 3.3 and 3.5, ASAM says not applicable in the absence of co-occurring cognitive problems or substance use requiring this intensity and type of service related to these dimensions of care, like readiness to change, relapse potential, living environment, problems that require this type of 24-hour care. A person with gambling disorder assessed to be unable to maintain their goals on an outpatient setting. And with this level of care, it's often abstinence, even given intensive outpatient programming. So if somebody is struggling and they can't maintain the goals with lower levels of intensity, or they're in imminent danger of harming themselves or others, then certainly we look to a residential level of care. Whether or not a specific co-occurring disorder has been identified. But certainly when we have a complex patient come in where there's substance use going on, where there's significant depression, may even be having some levels of suicidality, starting out with a residential level of care certainly might be recommended. Medically managed 24-hour nursing. Again, this usually requires some co-occurring medical or mental or substance use disorder to get that medically managed level of care, or medically managed intensive inpatient, where you have daily interaction with a physician. That's generally to assess the impact of meds on somebody who's fairly unstable with a mental health disorder. So let's look at Betty. Betty is 100% disabled and has been diagnosed with borderline personality disorder, schizoaffective disorder, post-traumatic stress disorder, and a seizure disorder. She's had multiple psychiatric admissions and multiple suicide attempts. She's been gambling since childhood, playing bingo with her mother and grandmother. She has a history of non-compliance with medication and seems to have poor coping skills for managing impulsive behaviors, including risky sex, spending, and gambling. So if you're handed Betty, what level of care to initiate her treatment for gambling would you be most comfortable with? Yeah, assessment 3.7. May want to, monitor her meds very closely. inpatient, inpatient. Yeah. Yeah, you know, and with someone like Betty with a seizure disorder, medical issues, as well as psychiatric issues, you know, a brief psychiatric inpatient stay, if that's, you know, available, and they understand the gambling piece, you know, you want to make sure she's stabilized medically and psychiatrically here. Now, that may be very brief, and in my experience, that works quite well with folks with a gambling disorder. They don't need 28 days on inpatient psychiatry. We just need to know that they're stable medically and psychiatrically, and then can move into residential level of care with monitoring of medications, depending on what level of medication the residential program can handle. Yeah, yeah. So you can see that these kind of complex patients, you need to have one in a safe environment. Monitor, is she suicidal? You know, is she taking the medications as prescribed? What are her seizures like? Are they managed relatively well? You know, do they need to be monitored? And once she's stable, then to that residential level of care or an intensive outpatient level of care. And Betty was that kind of a client, and, you know, 3 days on an assessment unit so everybody can feel safe, so we can make sure Betty's safe, and so we can feel safe that she's getting adequate care, and then step down to a residential program, and that worked pretty well. And here's a success story. After Betty went through residential gambling treatment until she died some 20 years later, she never had another psychiatric inpatient admission or medical inpatient admission. She was maintained after one residential stint in treatment on outpatient, ongoing outpatient support and recovery supports. So sometimes the magic works, and those stories we need to share. Yeah, yeah, yeah. One of my favorite clients. Challenging always, but, you know, had a lot of strengths that, you know, on the surface might not have been apparent at first. She was resilient, to say the least. And thinking about withdrawal management, you know, and people with gambling disorders go through withdrawal. They may have physical withdrawal symptoms. I've had clients who got dry heaves when anytime the news came on, because there would be stock market reports and they were stock market gamblers. So anytime that came on, they got nauseous for the first week or so of treatment. Severe agitation. So they look like they're having a manic episode or a psychotic episode. And they don't need meds. You know, I've spent hours pacing the floor of units with some clients just to get them to slow it down, chill out, manage that physiological reactivity. Vegetatively depressed looking clients as part of that withdrawal from gambling, headaches, anger, you know, a whole range of things. So it's not as consistent as with substance use disorder. It's not as predictable, but you got to be looking out for it. So may need some monitoring. Usually can be done on an outpatient basis, but at times needs that removal from the situation and for the potential for relapsing as a result of the intensity of their withdrawal symptoms. All right. So here's Jerry. Whenever Jerry stops gambling, he feels like he's going to jump out of his skin. He can't sit still. He paces around the house like a caged animal. He snaps at and yells at family members. He's punched holes in the walls. He feels like his mind is racing and can't focus. You know, and for Jerry, that would often trigger a return to gambling or an inability to stick to his goal of not gambling. If he didn't gamble, it would resolve in about 3 or 4 days and he'd be able to manage better. But those first 3 or 4 days were a real bear to get beyond. So where would we put Jerry? What level of care? .5, 3.5 or IOP. Yeah. If you had ambulatory detox, you might consider being part of an ambulatory detox or residential. Yeah, or something where his time was taken up. Now, we don't know, I mean, and if your IOP allows for somebody to come and go into IOP for a week and can accommodate that and has that flexibility, lovely. If your IOP says you got to sign up for our 8-week program, he may not need that. He may just need, you know, someplace to go and sit and have psychoeducation and the stuff that's involved in detox programs. It may be residential level detox or it may be outpatient level detox. Yeah, yeah. But what we're talking about here is just coping with his withdrawal symptoms and letting those calm down so we can figure out where to go next. Great thinking that through. All right, so before we move on to the dimensions of care, any questions or comments about levels of care and gambling disorder? Hopefully you've got a sense of how gambling needs to be thought of within ASAM's levels of care and what creative tweaks might be necessary. So even if you go back, if you're in an agency or an organization and look at how your agency speaks to levels of care, what would need to be changed in that discussion of qualifications for levels of care to fully integrate the realities of gambling disorder within that? And make sure, you know, gambling disorder is considered in terms of your levels of care. All right.
Hey, Dr. Rugle, there was a question about one of the cases, if you don't mind. It was from
Sure.
Marie, and she asked about Betty. Did Betty happen to do Gamblers Anonymous? Do you remember? Did she do a 12? Did she do a peer-based group or
Yes.
specifically
Yes.
GA? Okay.
Yes.
Wonderful.
Yes.
Okay.
She drove them crazy, but she did it. I mean, that was part of her resilience. She was one of the first 2 women in local GA.
Wonderful.
And she was not going to let them scare her off. And she made a point of talking about her sexual abuse in that room full of men in GA. And they weren't happy with that. They got a little uncomfortable with that, but she did what she needed to do. An amazing woman, amazing woman.
Good for her. That's great. Thank you.
Yeah, she broke them in well. Yeah, it was an important part of her community and her recovery plan. Yeah, so it was a positive thing for her. Any other questions or comments? Okay. All right. So ASAM's 6 dimensions of care plus my additional financial dimension. So the first dimension is acute intoxication and or withdrawal potential. And we've been already talking about this in terms of levels of care. You know, want to find out, have you had withdrawal symptoms? And folks coming into treatment for a gambling disorder may not even view what they've been through as withdrawal. So, you know, folks with substance use probably are pretty familiar with the concept of withdrawal or acute intoxication. And folks, when they're in the midst of a gambling episode, are acutely intoxicated. And in many ways, there's no talking to them. It just as there's no talking to somebody who's you know, drunk in the moment or high on drugs. You know, you don't want to waste your time trying to be reasonable at that point. You just want to get them someplace safe. And folks who are in the middle of a gambling episode, even if they've run out of money right now and they're not at the casino, but they're still in the episode. They're still thinking about where they're going to get money and how, you know, that's not the time necessarily to intervene, recognizing that acute intoxication. So we may have to educate our gambling clients that, yeah, you know, you're acutely intoxicated and your brain is on tilt at that point. It's not able to make rational decisions at that point in time. And what is it like when you stop gambling? So we may have to help them clarify, oh yeah, it happens every time. I'm punching those walls and I'm agitated and I'm screaming at them. That's withdrawal. I get these god-awful headaches that just won't go away. Or I go to bed and I don't get out of bed for 2 days. That's withdrawal. That's your body rebounding because it doesn't have an ounce of serotonin or dopamine left in its system. And so it's important to provide that context because they may not identify or understand that their experience is part of that intoxication and withdrawal, and helping them define what it looks like for them. So we wanted to have that certainly as part of our initial assessment and evaluation and talking with folks. Have you had these experiences? And not everybody with a gambling disorder does. So the variability is much different than substance use disorder and the predictability, as we've mentioned. Do you have any supports that allow you to tolerate any withdrawal that you've gone through without risk of harm to you or other folks, or without risk of returning to gambling to alleviate that withdrawal? Have they been using other substances? So withdrawal from the substances may be necessarily while we begin to deal with the gambling. And include things like caffeine. I had one client who came in having consumed 40 cups of coffee a day for years. We had to detox him from that. So yeah. And has gambling been covering up symptoms of other more chronic mental health disorders? So when you stop gambling, are these other disorders going to become more apparent? So Jeff has a history of trauma. He's had one hospitalization for depression, wasn't currently on any medications for any mental health problems. He gambles when he gets his disability check every month. He gambles online continuously until his money is gone. When his gambling binge is done, he is depleted. He can barely move, doesn't eat for days, doesn't get out of bed, and talks about killing himself. He owns a gun and keeps it next to his bed. After a few days, his mood begins to improve and he begins planning his next gambling episode. So in this little piece of information, which dimension of care are we talking about here? The fact that this resolves in a few days suggests that maybe, there's co-occurring trauma issues and co-occurring depression perhaps, but what we're talking about here as the most important thing to deal with is this withdrawal, this vegetative depression that's part of a withdrawal syndrome for Jeff. And certainly given his suicidal thinking during this phase, may want to put him in, a safe environment, a residential or inpatient level of care, at least for those first few days when he's going through withdrawal, to just make sure he's safe, and then into a less intense level of care to continuously address the gambling issues. Yeah, detox, absolutely. Inpatient, yeah, the suicidal ideation, make sure whatever level of care can monitor that suicidality. Certainly if you get him away from his gun, that's a huge step. Where you can assess further how imminent or how likely an actual attempt is. Yeah, absolutely. When you're talking about it and you've got a gun, take it very seriously. Always, 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 as you would with anybody else. But so often I've heard presenters or counselors say, oh, they're being manipulative to get money. They threaten suicide because that gets the money. It's always important to take this seriously and not think in terms of, oh, we don't have to attend to this because it's a manipulation. That's not only stigmatizing, but it's led to people successfully killing themselves. So always take it seriously, You don't say, okay, well, give them the money so they don't kill themselves. No, they need to be an appropriate level of care to be safe while we deal with these other issues. So it's not, we don't solve that by giving them money, or reinforcing their addictive behavior. We get them to a safe level of care as the appropriate response. Okay. Yeah, believe them. Absolutely. If a person is safe, then you can figure the rest out. Rule number one, keep the client alive as best we can. Yeah. Good responses, thank you. Dimension 2, biomedical conditions and complications. As we mentioned, folks with gambling problems have often neglected their physical well-being. And so we need to make sure that there aren't other things going on, that their, blood pressure isn't off the charts, that their diabetes is being well taken care of. I've had clients come in and been diagnosed with cancer when they thought that they were just having a backache, or they thought they were just getting urinary tract infections when they had bladder cancer. So you want to make sure that these conditions are evaluated and that they're in an appropriate level, like Betty, to monitor her seizure disorder and see how acute and problematic that was. And there can be acute conditions associated with periods of gambling. One client was constantly being seen in emergency rooms for dehydration because they didn't want to drink water while they were at their slot machine because they didn't want to have to go to the bathroom and leave their slot machine. So always something new. Medical conditions exacerbated by the stress of gambling, like hypertension, stress-related problems, headaches, back pain. Are they gambling as a way of getting relief from these medical conditions? I don't hurt when I'm sitting at my machine. Are they taking medications for medical conditions that might contribute to excessive gambling? Do folks know what those medical conditions are, where the medications for those conditions contribute to excessive gambling? What medical conditions or medications are you aware of? And feel free to chat those in. Or say, I don't have a clue. I don't know. Parkinson's, yes, yes. What's another one? Parkinson's is one. We'll find out in a minute. And chronic conditions that complicate treatment, like traumatic brain injury that influences frontal lobe functioning, that we know is involved. No, not diabetes. Not sure. Okay. It'll be coming up in just a moment here, because we're going to revisit Sue Ann. So another piece of information I didn't give you before. Okay, she's been able to gamble without any problems and enjoyed it. And just recently, she just can't control it. And she tells you she's recently been diagnosed with restless leg syndrome and started on some medication. Okay, so restless leg syndrome is the other condition, along with Parkinson's, that folks are often given these dopamine agonists, dopaminergic medications, and two of the newer ones that exacerbate gambling problems, Requip and Mirapex, can be this dramatic. I could, go to the casino twice a year and enjoy it. And I started taking this medication, and I'm now going every day, and I can't stop. I don't know why. Those stories trigger, what medications might you be taking? What's recently been diagnosed? It can be that dramatic. And so this one is clear that we're talking about a biomedical area as the primary dimension that we need to be addressing. The first thing we want to do is get a release of information so we can talk to her neurologist or whatever physician is prescribing this medication. It's nearly impossible when you get a history like this and the medication is involved and has that impact on the individual for them to be able to control their gambling, no matter what we do counseling-wise. It seems impossible for these people to get a grip on their gambling as much as they want to, as much as they do everything you tell them to do. They go to GA, they go to, self-help groups, they give somebody else access, and management of their money. And they still gamble with every penny they can get a hold of, and they don't understand it. So you want to change the medications if possible, find some other medical interventions that might be helpful. Or if worse comes to worse, if this is the only medication that works, and for some people this has been the case, to relieve these really difficult symptoms of Parkinson's or restless leg, then we do our best to protect as much of their resources as possible, because they're just not going to be very successful controlling their gambling behavior. So we have to find other ways of setting those limits very often. Yeah, yeah. So, and if we can work with the neurologist and talk with them, I sent them articles sometimes. Most neurologists now are getting informed about this, but early on I would send them all the research articles showing the connection. And they can, often titrate, reduce one medication, add another, and do that kind of creatively around them. The other, not for Parkinson's and restless leg, but for mood disorders is Abilify. Not often as dramatic, but still can make it really hard to get a control over the gambling behaviors, because it seems to exacerbate the disinhibited gambling behaviors. So if somebody has a mood disorder, always make sure you get an accurate list of the medications. That, oh, my doc just prescribed something new. I don't know. Well, bring it in with you next time. Let's check it out. Okay, good job, good job. And dimension 3, the emotional, behavioral, cognitive conditions and complications, all the co-occurring disorders. And one study found that, over 90% of folks in this epidemiological study had at least one other co-occurring disorder. So co-occurring disorders tend to be the rule rather than the exception. So making sure that you assess for the depression, the anxiety, the trauma issues, which are so prevalent, either childhood or adult trauma. Also, folks with serious psychotic disorders, schizophrenia, schizoaffective disorder are at higher risk. Attention deficit disorder, autism spectrum disorders, especially as we add in video gaming disorder to gambling disorders. So much of a co-occurrence with ADHD or autism spectrum disorders, as well as other mental health issues. And what's the interaction? Does the gambling provide relief from my depression, my anxiety? Does it exacerbate, and it probably does both. While I'm in the middle of a gambling episode, while I'm actively gambling, I feel relief. I don't have the intrusive traumatic memories. But then when I'm done, it all comes back with a vengeance. I'm hearing my voices even louder because I'm feeling stressed and guilty. I'm even more depressed than I was because now I've lost a whole bunch of money. My anxiety goes sky high. So we need to help people understand that interaction. And as we've talked about, the suicidality and the lethality of that. And real specifically asking that, since the suicide rate is so very high among folks with gambling disorder, what medications are they on? How are they taking them? And all that stuff we do about the co-occurring disorders. So certainly making that connection that gambling seemed to be a great cure, but the long-term effect can be that exacerbation of the mental health and emotional distress. And readiness to change. Does this individual feel coerced into treatment or actively object? Now, we don't get that so much. There aren't so many court-ordered clients where that may be an issue in terms of gambling disorder. But maybe they're feeling coerced by family members. And they feel like they have to say, I want to stop, because that's the only way they can stay in the marriage, in the relationship, in the home, in the job. So getting beyond that to understanding, what their real ambivalence may be, is important work. Not what they think they have to say, but what's really going on. And what are they ready to change? Are they ready to stop? Are they ready to set some limits or reduce the harm of their gambling? And we taught that should be part of the standard approach. What do you want as your goal? What are you motivated to change or not to change in terms of your gambling, and starting there? If they're willing to accept treatment, what are they aware of in terms of how problematic the gambling has been or what harms are related to their gambling? And, appreciating the external as well as the internal motivations. Both are very real. And tagging, it's always about, what do you want in your life? And how is gambling connected to that? How is gambling helping you achieve what you want, or how is it a detriment to what you want to achieve? But always starting with, what do you want? Even if it's not gambling related. I want to go back to college. I want to get out of this relationship. Okay, that's where we start, and we play connect the dots. But assessing this as its own dimension is critically important, so we know where we're starting from and how what we do is related to the client's pre-contemplation, contemplation, or readiness to take action. And the sixth, relapse or continued use. No, this is 5, problem potential. Often, many of our clients aren't aware of what can be activating or triggering. So just starting with, what does trigger you? It's not just, boom, there I was at the casino, don't know how I got there. Let's trace it back. So a lot of that work in understanding what's activating, what's triggering, how they get from point A to point B. How preoccupied are they aware of any cravings? Are they aware of the thoughts? Do we need to help them monitor these things to become more aware? Do they have any skills to cope with the triggers, to experience a trigger without activating a gambling episode or out of control gambling? Have they ever been able to do that? And are they at immediate risk for continued severe distress in gambling or other high-risk behaviors due to co-occurring conditions like substance use and mental health? So let's look at Tony and put this a bit together here. Another one of my favorite clients. Tony was referred by members of Gamblers Anonymous. He states the group is fed up with him continuing to gamble. They don't know what to do with him. He's been in and out of GA for many years. He has no debt and lives very simply on quite a limited budget. He's 82 years old, divorced, a Korean era veteran. His mother died when he was quite young, and he was raised by an abusive aunt. He had an older brother with whom he remained very close until his brother died about 6 years ago. They had enjoyed boating and gambling together. They'd go on junkets to Atlantic City. He is a high school graduate. He played football in high school and the military, completed some college courses, and he still enjoys boating and painting. He married after he was discharged from the military. He has 3 children, 2 daughters and 1 son. So when we started out, his 2 daughters were married and his son was engaged. He had 5 grandchildren. He currently saw the kids and the grandkids only rarely, and he was feeling pretty alienated from the family. and quite guilty about not being a good provider. He'd held a variety of jobs throughout his career and owned several small businesses. He enjoys playing cards and trips to the casino with the senior center. And on his own, he has some unsuccessful stock market investments that depleted his college fund for his son. He took the advice of a friend and put all of his money in one stock right before the recession. Currently lives in an apartment by himself. He has a lady friend who he sees about once or twice a week, plays bridge and pinochle and bocce ball at the senior center. He still would like to play golf. He helps his neighbors by giving rides to appointments and for groceries. Ideally, he would like to go to the casino about once or twice a month and take about $200 and not spend more than that. That he can fit into his budget. So, what dimensions of care that we've talked about seem to fit or be in need of addressing for Tony? What dimensions of care? All right, what are people saying? 2, 3, and 1. 1, withdraw. Need more info. Think about Tony's goal. He wants to go to the casino a couple of times a month. When he was going to GA, was that a good match? No, Gamblers Anonymous are for those who want to stop gambling. They were frustrated with him and he was frustrated with them because their goals were inconsistent. He did not want to stop gambling while it was creating financial strain for him. You know, he was pinching his pennies and he was stressed out because he typically went beyond what he could afford in his budget. He didn't borrow money, fortunately, which kept those losses to a minimum, but he was stressed out every month. And the reason he was alienated from his family was because he never had the money when they invited him to birthdays, to holiday gatherings. He felt so ashamed that he didn't even have money to like bring a bottle of wine as an offering for the gathering. For his grandkids' birthdays, he couldn't afford presents for holidays, so he just wouldn't go. They wanted to include him. They invited him for everything. So the gambling was creating distress in his life. But he also saw it as wanting to create a legacy. The only way he thought he would have a legacy to leave to his children, to replenish his son's college fund, and to contribute to his son's wedding as we worked. One of his goals was, I want to contribute to my son's wedding. And he thought gambling and winning gambling was the only way to do this. But he wasn't willing to give up that hope. So what we're talking about here with Tony really is readiness to change, and readiness to change what? He was not ready to stop gambling. So working with him on how to stick to his limits, how to limit the damage gambling was doing, how to set aside money for his son's wedding, and devising strategies to do what he wanted to do not only in terms of limited gambling, but also in terms of having that legacy, being part of the family, having something to offer, were really important issues. So that readiness to change was key. If he'd come in and all we did was work on stopping gambling, because that's what he thought he was supposed to do. He came in thinking he had to, see a counselor to stop gambling, and the counselor was going to do what GA couldn't. But when it became clear that that really wasn't the goal he had in mind, we shifted the focus. And he was able to save up some money and limit, not perfectly, the amount he spent and the number of times he went gambling, and give money to his kids before he went gambling. So he just started giving money to his son to save up for the wedding. He already had given some money to one of his daughters, which was his funeral fund. And also the other issues, getting him to be re-involved with his kids and going to his grandkids' sporting events. And this is another happy ending story. They aren't all, but let's savor the ones we do have. He did give money, and he was so proud, and had this picture of him in his tuxedo, at his son's wedding, toasting, giving the toast, being recognized as having a right to be there. And he felt he had that right because he had contributed financially. And he was so happy and proud of that. And also his daughters threw a lovely 85th birthday party for him on one of these river cruises, boats. And he just felt so delighted that they cared enough about him, and that these other people and friends came who cared about him. It was just lovely. And, he didn't do it perfectly. Sometimes he'd go to the ATM machines when he didn't leave his card at home, but overall he did a whole lot better and was able to have money for what he wanted to and re-engage with his family. And it was by recognizing what he was ready to change and what he was ambivalent about, and not forcing him to be ready to meet my goals, but understanding what his goals were. Living environment, being in abusive relationships, recovery environment, having too much access to money at work, on the job, other people's funds and resources. Do you have any supportive friendships, family relationships? Are you homeless? Barriers to treatment. I have to keep my job. I can't keep taking off of work to come to appointments when they're convenient for you. You have to make the time convenient for me so I can keep my job. Really important considerations. Charlie, widowed and works as a custodian part-time, gambled away all the inheritance after his wife died 5 years ago, living with his oldest son and daughter-in-law and grandkids. His son is extremely verbally abusive and drinks excessively. His son is really mad that dad gambled away the inheritance. Charlie's increasingly depressed and feels trapped by this living arrangement. He's been treated for depression for many years, but never the gambling. And following a suicide attempt, he's referred for gambling treatment when it comes out that gambling has been a part of this. So clearly, living environment, this abusive living environment, was just wearing him down. We had the son and the family in for treatment, and tried many ways of just talking with the son, of talking with the son and his wife, of having them all together. And it was toxic. And we just could not help begin to change that dynamic. And the son was controlling all of Charlie's finances and wouldn't buy him the simplest self-care things that Charlie wanted and needed. So we worked in an opposite direction, realizing how toxic this environment was. We helped Charlie get out of that environment and regain control of his finances and be helped with another one of his kids rather than this son, for accountability. Yeah, no. So that dimension of care is that living environment that can need intervention. And we were, after the suicide attempt, and he had an inpatient stay for the depression and the psychiatry, when he came to us, he looked almost vegetative still. We actually managed him on an outpatient basis, supplemented with some family work and some individual work, and eventually involvement in group. And as he had somebody who was affirming him and not just yelling and screaming and abusing him, the vegetative depression resolved in collaboration with psychiatry and, medication for that as well. It was a team approach. And then eventually helping him find a non-toxic living environment was key. And financial, even though ASAM does consider finances as part of this living environment, it's so critical to working with gambling disorder. I really wanted to highlight it. So I suggest the seventh dimension, financial. And we got to talk about the finances. What are the financial consequences? What are a person's financial resources? Do they or anyone they are trusting have the capacity to safeguard their finances from excessive gambling or a relapse to gambling? Are the financial circumstances an obstacle? And by that, I think of what I think of it as trust fund people who have, access to large amounts of money ongoingly. And that can be even people on disability incomes where they get, more money every month. They may blow through that every month, but then they've got that other check, and that can be a barrier to recovery as well. Too much money and too little money. And is access to money or the lack of it a significant risk factor for continued gambling? So we need to protect the money from the gambling, and develop a means of doing that. We need to look at the financial situation, and that includes developing a budget, maybe developing a restitution plan for any debt related to the gambling, making changes if the amount coming in does not equal the amount going out, and make those living adjustments that can be very painful. So lots and lots of issues around money when it comes to gambling. Dave, a 54-year-old male working 3 jobs just to try to stay afloat, paying off gambling debts and not lose his home. His wife has been overspending as a way to cope with her depression and anger. He sees no way out from their financial situation other than to score a big win. He's been gambling on horse racing since his teens. He's tried GA in the past, but always relapses after a few months. He has chronic back pain and takes prescription medications, mostly as prescribed. So you see many of the dimensions here medical conditions where gambling relieves the pain, relationship issues, mental health issues, depression. But what was key with Dave was that he was killing himself working these 3 jobs. Of course, he had fantasies and thoughts about if I just score the big one, I can quit 1 or 2 of these jobs and not feel like my life is nothing, that I have nothing to look forward to. He was exhausted all the time, understandably. So focusing on the finances and helping, to look at various solutions to this. It's certainly dealing with the wife's overspending. They needed help in developing and sticking to a budget. And he had so little energy, he couldn't take charge of this. The wife certainly wasn't in a position to take charge of it. We employed an adult son who was pretty stable and reasonable to help them structure their budget. He didn't take charge of their finances, but he met with them to help structure the budget, to look at it realistically, what was possible. How much could mom stop spending? Was filing bankruptcy an option to save the home? And after we looked at all other options, decided that, yeah, filing bankruptcy, and that took about 6 months, made sense, which allowed them to save their home, to relieve the debt burden, and allowing him to stop working so much. He could let go of at least one of the jobs and part of, a second job. So he was just working 1 job and a part-time job rather than 2 full-time jobs and a part-time job. And they actually went on a vacation. She worked part-time for a hotel chain. So she had free hotel rooms, and they went, to a local community, stayed at a hotel on lovely Lake Erie. So he saw some hope that there was some way to get relief other than just scoring a big win. But dealing with the finances was the primary issue that gave that relief. Okay, last poll.
Okay, poll number 5. Let's get
You're still awake.
Okay, here we are.
All right, dimension 1 category. If you could, now this does require some memory. Okay, all right, what is dimension 1? All right, people have good memories. A little bit more variability. Okay, I think we've got most folks, and we'll end the poll and share the results. As you can see, most people pick C. Yes, that's correct. Acute intoxication and or withdrawal. Very good. All right. So a very quick run through ASAM criteria, dimensions, levels of care, guiding principles. So for you to think about, and perhaps type into the chat, where do you see the gaps in your continuum of care for folks who are at risk for or assessed with having a gambling disorder? Where are the gaps? We've all got them. We all have them. And what's one thing that you might do to begin to improve? Doesn't mean fix it right away, fill it in immediately. No, what's one little thing that you can begin to do to begin addressing. Maybe put it on the agenda of a staff meeting. Maybe get some information or some resources that people can use to beef up the continuum. Maybe do an in-service for your agency. And what would you recommend to your agency or system of care to do this a little better, to develop this continuum a bit more? Let me see what's chatted in here. If a client comes in with both a gambling issue and substance, the substance always takes precedent. That might not always be the case. Absolutely. Absolutely. Don't assume just because that's what you primarily do, that that's what primarily the client cares about. So start where the client is asked, what they'd like to work on first, what they think is most important. Yeah. Offer more community intervention regarding gambling. Very good. Yeah. From inpatient to outpatient. Yeah. Having more gambling information out in the waiting room. Yeah. Good place to start. Pick the low-hanging fruit. Get some posters, put them up. Yeah. Offer to do a psycho-ed group once, few weeks. How to have fun in recovery. Absolutely. Put it into your class on financial recovery, dealing with money in recovery, what to do with your alcohol and drug money in recovery. Have fun, do this playfully and creatively. Good ideas. Well, you are now deputized to be continuum of care expanders in whatever setting you find yourself. Thank you so much for your kind attention and participation and lovely, lovely comments. Yeah.
Yeah, thank you again, Dr. Rugle. I love this training because of the interactive piece, and it just took this group a little bit of warming up, but I tell you what, they finished strong, didn't they?
Absolutely. I couldn't keep up with them.
Exactly.
I hope I attended to everybody's comments.
No, you did great. I was trying to see if I should stay back or not, but everybody did great, and I think you got to just about everything. And what I love about this training, I had the fortunate circumstance of being able to sit in on it a few times, is it's so interactive with real life cases, some things that we can actually apply in our work. So I really appreciate your experience and sharing your knowledge with us today.
Well, great. Thank you all so very much. Yeah. Live long and prosper.
Very much. Okay. Yeah. Thank you.
Go forth and multiply.
Yeah, exactly. Thank you very much again, Dr. Rugle. And thank
you.
you for everybody
All right.
participating and being on. Have a
Take
great
care,
day.
everyone. Bye-bye.
All right. Bye.